Okay, so good afternoon. First of all, thank you. I would like to thank Martin and Thibault for the kind invitation to be here. So, as usual, I have the pleasure to dance with the ugliest one today again, for me in this case, but let's do my best. Okay, so treatment of short saphenous vein, as you know, is probably the most dangerous scenario for thermal ablation. And what is clear that we have to know that treatment with HIFU with Sonovein is a thermal treatment, so we have to consider that as the initial. So we have published our experience with different types of veins last year in phlebology. So we have published our results with 15 short saphenous veins treated. We have already now experience around 40 veins treated of short saphenous veins. And what we have to consider that obviously small saphenous vein is not the great saphenous vein. It has its characteristics, it's shorter, usually more superficial. We have to take care with variable indeterminations in the popliteal fossa, and especially the anatomic relationship with nerves that will imply possible thermal damage. So, can we treat short saphenous vein with the HIFU with the Sonovein system? Yes, we do, but we have to get some general considerations. This is the HIFU itself. You know, we know that we are always at delivery of residual thermal energy posterior to our focus area of impact with the HIFU, and even a reaction and a fibrosis in the perivenous tissue when we generate this thermal ablation. So we have to try to avoid this over-treating, like you can see in the yellow image in the left. And regarding technical considerations, what we know is that for sure the use of the superficial pulses, especially the 1 second pulse, could be essential to get success in this area. And to treat the short saphenous vein, we will have to treat less length, especially if you are practicing ablative approach as I do. And then we have to get maybe a little more difficult to make a complete compression of the short saphenous vein than in the great saphenous vein. And we have to be carefully with the anesthesia protocol, and then I will explain you later why. Regarding the safety considerations, it's important to consider two scenarios. The first is the relation with the tibial nerve in the popliteal fossa. This is mandatory. Why? Because as you can see in the image, the vein is, the nerve is practically, in the major part of cases, attached to our target vein. So what we can do to prevent this? Well, we can inject saline, especially to make a space between the vein and the tibial nerve, and after do our local anesthesia protocol. We have always to try to be inside the saphenous compartment, because if not, it will be easy to put the patient inside the room, but you will have problems to take it out because he or she will not be able to walk anymore for a couple of hours if you make anesthesia over the tibial nerve. So important this consideration. And after, obviously, the sural nerve. You know that when we arrive to the crura, distally, this sensitive nerve, it's often very, very attached to the short saphenous vein. So in this case, we can separate it, but I would recommend just to detect what is the place where the nerve is inside the saphenous compartment and stop your treatment at this level. So to show you some examples, you can see here how the vein is treated in the short saphenous vein, how superficial it is. Look that we are treating veins in less than 1 centimeter usually, 7 to 1 centimeter. This is a result after 6 months follow-up. You can see the shrinkage clearly of the vein in the second video. This is another case that you can see where the saphenopopliteal junction is fully occluded from the beginning, and how close is the tibial nerve. You can see the image here, how close you can identify easily the nerve at these sites, and how in the control you can see how the vein is occluded and it's practically attached to the tibial nerve without damage. In this case, no problems at all. So we use the saline to separate this nerve from our target vein. This is a clinical results of another patient at 12 months follow-up without no paresthesias and no problems at all after treating the short saphenous vein with the Sonovein system. So that's our experience regarding numbers of these 15 short saphenous veins that we treated. We have a really good occlusion rate at 12 months. You can see 87% with achieving a shrinkage and absence of reflux in all these veins treated, and with improvement in the C-class and venous clinical severity score in all the cases. So just in summary, for me, HIFU therapy with the Sonovein system is today a real and valid treatment option, even for the short saphenous vein, but we have to be a little bit more careful in this case. And we have to adapt the treatment to each patient, but we know that we have, in this short saphenous vein, a good occlusion rate, 87% at 1 year follow-up, and probably with the advance and the evolution of the technology, we can be treated more, easier, and safer. Thank you.